Alright, so this is lecture 1 of our resident venous lecture series, and we're going to focus on pelvic congestion syndrome. These lectures are dedicated to the diagnostic and interventional radiology residents at the Mayo Clinic in Jacksonville. Obviously, anyone watching this can benefit from the information, but that is the target audience. The goal here is to make some short 5 to 10 minute lectures on various topics in venous disease. So we're going to start with pelvic congestion syndrome, and we're going to review the anatomic categorization and clinical workup of this disease. I have to put this quick disclaimer that this is for educational and information purposes only. It does not constitute medical advice, and obviously none of the information here represents the opinions or thoughts of the Mayo Clinic. Okay, so pelvic congestion syndrome, it's often referred to also as pelvic venous insufficiency. So these often refer to the same thing. Why does pelvic congestion syndrome matter? Well, it matters because it's a significant worldwide problem, and it's often under-recognized and under-treated. It is a venous issue which can be associated with severe physical, emotional, behavioral, and even sexual pain. And it's also important because there are effective treatments available once it is recognized and identified. Pelvic venous insufficiency, it's associated with chronic pelvic pain, and as I mentioned, it has multiple negative cognitive, behavioral, sexual, and emotional consequences. It can result in significant morbidity, and it can affect up to 24% of women worldwide. This entity was first recognized all the way back in the 1820s, and even though it has gained increasing literature focus, it's still largely under-recognized, underdiagnosed, and it's often inappropriately treated. So pelvic venous insufficiency or pelvic venous congestion, it's really a diagnosis of exclusion, and one really needs to do a careful workup for other causes to make sure that there is nothing else causing the chronic pelvic pain. The most likely other causes that can be contributors or the source of chronic pelvic pain are endometriosis, pelvic inflammatory disease, fibroids, adenomyosis. There's other urologic causes, neuropathic pain, as well as GI and musculoskeletal. So now that we've done a little background on pelvic venous insufficiency, let's start by discussing what causes pelvic venous congestion and how to categorize it anatomically. So I want to give you a framework for how to understand the anatomy of this disease. Okay, so I really like this figure because it kind of shows all of the interconnected pathways. So here you've got the pathway that involves the left renal vein from the left kidney. You've got the left ovarian vein right here, which drains into the left renal vein and supplies an outlet from the pelvis. And then you've got the left common iliac vein right here, which is connected to the pelvic reservoir through the internal iliac vein. So you can see that all three of these pathways are connected with the pelvic reservoir. So the first type of pelvic congestion syndrome can be due to gonadal vein reflux from nutcracker. So what does nutcracker mean? It means that there's narrowing of the left renal vein right here as it crosses the SMA, and since blood can't go forward, it results in backwards flow through the ovarian vein and into the pelvis, and this causes congestion of the pelvic veins. So that's one anatomic form of pelvic venous congestion. The second can occur when you have a May-Thurner narrowing. So what that means is there's a narrowing right here of the left common iliac vein by the overlying right common iliac artery. And again, this results in backwards flow into the internal iliac, and again, this can cause congestion in the pelvis. So this is the second type of anatomic abnormality that can cause pelvic venous congestion. Finally, the third one is you don't necessarily have a narrowing causing compression and backwards flow, but the left ovarian vein has simply become incompetent, and instead of having blood flow forward, it flows backward and congests into the pelvis. This often happens in multiparous patients and those individuals that have had increased estrogen. There's also a genetic component which causes incompetent valves. This can happen in the left or the right or both ovarian veins. So I want to review one more time because it's important that these three systems are all interconnected. Zone 1 is really the left renal vein. Zone 2 includes the gonadal vein. and then there's zone 3 with the pelvic veins, and then all of these zones can escape down into zone 4 and cause varices of the leg. So this is a very simplistic diaphragm, but the anatomic categorization of this is very important, so I'm going to review it one more time. So again, we've got the left kidney here, and this typically drains into the right atrium like this. However, if you have an obstruction right here, blood will no longer go antegrade from the ovarian vein into the left renal vein, but this obstruction can now cause it to go backwards, and it will go down the gonadal vein and obstruct in the pelvis here. Similarly, the common iliac vein typically sends blood this way, but if you have an obstruction right here, the blood will go backwards through the internal iliac and congest the pelvis. These are the two anatomic ways. Additionally, basically, if you have any anatomic narrowing here, you can also get blood that flows backwards into the internal iliac on this side and on this side and congest the pelvis. Finally, aside from the anatomic narrowings, you can have primary incompetence of the left ovarian, which causes backwards flow here, and the right ovarian, which also causes backwards flow into the pelvis. And lastly, once these veins become incompetent, there are escape points or connecting veins which can then cause reflux down the leg and cause varicose veins in the leg. So you can see here all of these systems are interconnected, and that's why it's so important to take a detailed history of the patient to try to understand where the abnormalities truly lie, because there can be more than one at the same time. Now that we have a good anatomic categorization of this disease, let's do a quick discussion of what exactly is the pathophysiology of pelvic congestion syndrome. Well, it's unclear. There are two theories. The first is you have this sort of dilated, boggy veins in the pelvis. And similarly to having dilated, boggy veins in the legs, it's this sort of pooling of blood and the stretching of the veins that itself causes pain. There's a second theory, as you can see on these laparoscopic images, that perhaps these dilated veins are compressing adjacent nerves. So there's a theory that it's the physical compression of the adjacent nerves. It is probably some combination of these two which causes the pain. One more very important note here is that these anatomic abnormalities that we have been discussing can be seen in asymptomatic women. The important thing is that when you find these abnormalities on a CT, MRI, or ultrasound, they have to correlate with the clinical exam and the findings to determine whether these abnormalities actually matter and need to be treated. So let's go over what we need to figure out from the patient to determine if they have symptoms consistent with pelvic congestion syndrome. So first, you need to obtain a very detailed history of present illness regarding their symptoms. You want to know their prior diagnostic workup, etc. You want to know a detailed past medical and surgical history, and you want to know all the medications that the patient is on, especially if they're on any estrogen, progesterone, and blood thinners. Next, what exactly are the clinical symptoms of pelvic congestion syndrome? Well, first, as I mentioned, it's a diagnosis of exclusion. So you want to make sure that you've excluded other causes before you start thinking about this. Pain is typically present for at least 6 months, and it should result in a functional disability. The most specific complaints that patients will have is pelvic pain and fullness. They can have pain with urination. They can have pain with intercourse. The pain is often described as a deep type of pain. If they have superficial pain, that may be from adjacent varices. Pain can be cyclical in nature, but in general it tends to always be present. Like any venous disease, it improves when the patient lies down, it's worse at the end of the day, and they can have postcoital pain that can be prolonged as well as dysmenorrhea. So these are the important questions to elicit. Patients may report vulvar, upper thigh, buttock, or lower leg varices through those escape points that I had mentioned. and there will typically be pain at the ovarian point. So if you draw a line from the umbilicus to the superior iliac crest and you go 1/3, this is considered the ovarian pain, and most classically where the pain is described. What are the clinical findings of the disease? Well, there's not too many clinical findings because this is a disease of congested veins in the pelvis. However, if a bimanual examination is performed, there may be focal adnexal tenderness, again at the ovarian point, which I had described. You can see varicose veins of the vulva, which are present here. And if the blood goes through escape points, you can cause varicose veins of the thigh. And this is via the pudendal, sciatic, and gluteal vein escape points, where the blood now congests from the pelvis down into the leg. Finally, it's important not to forget other interrelated venous pathologies. So if you think the pelvic congestion is due to nutcracker, you also want to make sure that they don't have flank pain, hematuria, or proteinuria. And if you think it's due to a May-Thurner compression, you want to elicit if there's any lower extremity swelling and pain. In addition, don't forget about other interrelated pathologies. So patient with POTS, these have been shown to more likely have May-Thurner compression, which as we learned can result in pelvic venous congestion. And PCOS has been shown to be correlated with those patients that have pelvic venous congestion. And this may be through a hormonal link. So an increase in estrogen, which can be seen with PCOS, may be causing pelvic venous congestion through its secondary effects on the valves and the actual vein. Now that you've talked to the patient and you're wondering, does this patient actually have pelvic congestion syndrome? Well, there's no specific criteria currently available. What you want to think about is, do they have an appropriate history and symptoms that fit with PCS? Have other causes of the pain been excluded? Again, you want to do an in-depth analysis here, including urologic and GI causes. You want to make sure that your clinical exam also fits with pelvic congestion syndrome. And finally, you want to make sure that you've investigated other interrelated pathologies such as nutcracker and May-Thurner. Once you have done all that and you determine that your patient fits the clinical criteria for PCS, what's next? Well, next is confirming the diagnosis with imaging, which is going to be our second lecture. All right, thank you guys so much for listening to this lecture. I hope that it was helpful. This is lecture 1 of the Resident Venous Lecture Series, and feel free to email me with any questions.